right, welcome to Heart Month, all right? We've had a really good lunch. We've had a little bit of heart healthy and a little bit of not. Okay. In all honesty. But you know, it's a good, healthy balance, isn't that what we tell ourselves? But we had a good fellowship time. Now we're going to learn more about our heart. Hey guys, it is that #1 killer, right? We read that all the time. It's important for us to know the signs and symptoms and what we should think about, how to be healthy, what matters. So today, I think you guys are all back here to hear Dr. Schultz because he is absolutely phenomenal. And we are so fortunate to have him at Coosa Valley helping to run our cardiac program. He does such a great job. So I'm not going to stand in the way today of what he has to say. I know we got some good questions at the end, Dr. Schultz, so we'll save those. But again, we're so thankful that you're here. We're thankful that we got up this morning and that heart was still ticking, right? Yeah, when that doesn't tick, then we don't get up. So we got a lot to be thankful for. But with that, let's give Dr. Schultz a big hand.
Can you all hear me?
Oh, yes.
Okay. So, I guess an explanation is in order. Normally, I like to walk around here up front and things like that, but I have to get a knee replacement in a couple of weeks, and so I'm not really the most mobile, and I don't really need to fall down on the ground, so I'm just going to sit and talk with you today. So in the past, we've talked about a lot of things with relation to the heart, you know, that worry us. Things like coronary artery disease and heart attacks and heart failure, which are all very important. But I thought what I wanted to talk a little bit about today is something that I see just a load of consults in the office for, is something called palpitations. And palpitations is really a symptom, you know. So patients don't come to the office and say, oh, I'm having palpitations. They'll say, I'm feeling my heartbeat, or my heart is racing, or something like that. And it's kind of disconcerting to them because, you know, if you're in normal rhythm and you're just sitting there, you don't normally feel your heart. And then all of a sudden, whoa, what is this that I'm feeling? And so this is what, now that looks like the universal sign of I'm having a heart attack, but it also happens to be the universal sign of, hey, I'm feeling something funny in here. Can't really put my finger on it, but I know it's not normal, or I'm waking up from it in the middle of the night, those kind of things. So what is a palpitation? So I like to call it kind of an abnormal awareness of your heartbeat. You know, when you're not used to feeling your heartbeat, and it does, or you feel a skip, it skips out of turn. So normally your heartbeat should be kind of like music. And if you just kept time to it, it's really regular, like you would for the beat of a song. But all of a sudden you might have a skip come in. Some people will complain that their heart is racing. I hear this, hey, there's a butterfly in my chest. It comes in and it's there and goes away. Or they may say that my heart's jumping. Palpitations can come regularly or irregularly, and that'll be helpful in us figuring out exactly what the nature of the palpitation is. And most frequently, it's not associated with chest pain per se. I feel my heart, but it's not hurting, and when I do stuff, I do fine. And so, you know, most people want to specifically say, hey, that's not chest pain, because they don't want to go down that road. So, what are the main causes of palpitations? Well, there's a lot of things about lifestyle that can cause all of a sudden your heart to kind of want to be out of rhythm. And we're going to talk about some of the reasons and different kinds of rhythms that can cause you to have palpitations. Some of them are very benign. One of them I want to talk about more specifically, we have to be a little more concerned about. But just simple things like being dehydrated, having a thyroid problem, being anemic, not sleeping enough, stress. You know, I never say that stress causes heart disease, but I always say that it sure can make heart disease worse. And actual rhythm problems. And so, you know, so on those top ones, we are talking a little bit about, hey, what can I do? I need to drink a little more water. I need to probably get a better night's sleep. I need to constructively handle the stress in my life. When you all figure out how that's done, you let me know. But it's those type of things. Now, this is kind of a cartoon of the heart. And, you know, your heart kind of has three parts. There's the heart muscle, that's the pump. It's got arteries that lead to it to feed it oxygen, that's called plumbing. And then we have the electrical department. So you don't want your heart to have little bits of it beating all the time. You want your heart to beat all as one so that it pushes the blood out and keeps it circulating. So because of that, we have some special cells in our heart that are able to conduct electricity. And if you look at that top yellow button up there, that's, so that, let me give you a little talk through the cartoon. So RA and LA are left atrium and right atrium. Those are the upper chambers. And then the left ventricle and the right ventricle are the lower chambers. The right side is what pumps the blood into the lungs to be oxygenated. The left is what pumps it out into your body to send oxygen to your body. But the normal heartbeat starts there in what's called the SA node, which stands for sinoatrial node. It's kind of the normal pacemaker of your heart. Now, if your heart rate's 60 or if your heart rate's 90, that's what's causing it. So all that electricity goes around the top part of the heart, and then it goes to a thing called the AV node, which is the atrioventricular node. And that's kind of sitting right between the upper and lower chambers. And what it does is it kind of collects all the electricity just for a little while, and then releases it to the bottom of your heart so the left and right side will beat together. So that's kind of what a normal electrical activity of your heart is like. Now, how do we measure, what the electrical activity looks like? And so the most common way, and probably everybody in this room has had one, is an EKG. Now, on the left is kind of the classic EKG machine that you see when you come to the doctor. But now that we're in the 21st century, there's all kinds of other ways that you can get your EKG. There's a CARTIA device, which is there on the right, and you put your fingers on there, and it prints out an EKG on your tablet. And we now even have watches that are able to look at your EKG, and in such a way that you can actually even send them to your healthcare provider. So there's more than one way these days to get an EKG. But the way we make the diagnosis, particularly of electrical problems, is from the EKG. So this is just a normal EKG. You're going to learn a little more about EKGs than you probably care to today. But that's a normal 12-lead EKG. So when you go to the doctor and they put all the stickers in different places and all around here, that's what gets printed out. But I think it's a little easier to kind of look at it like this. This is just a rhythm strip. That's one of those leads. And the way that this EKG and a normal beat looks like is it's made up of a small hill, a large hill, and then kind of a medium hill. The small hill, which is called the P wave, is when your upper chamber contracts. The large hill is when your lower chambers contract. That's called the QRS. And then the T wave is actually when your heart is resetting electrically to get ready for the next beat. And so you can see down in the electrical strip down there, small hill, tall hill, medium hill. And that's going to be important because we're going to be able to see some differences today in some of these rhythm problems we're going to talk about. Now, the first one I want to talk about is premature beats. What are premature beats? They're beats that come prematurely, hence what they're called. And so, you're beating along, and whoop, little one jumps in there like that, and you feel that little skip. So these are frequent. Almost everyone has them. So if you ever wear a heart monitor and we get the report back, everybody's got some premature beats in there. Now, you may feel them, you may not feel them. And these premature beats can come from either the top or the bottom of your heart, either one. Mostly considered benign, 99.5% of the time, and they rarely need treatment. So this is called a premature atrial contraction. So you see, we've got our strip here, and we see our normal hill, but you see how that third one comes in a little bit early, and then after the regular beat picks up. Now the thing that people tend to feel with this is not the premature beat. What they feel is that little pause. So you got an early beat that comes, and then there's a compensatory pause while your heart gets kind of reset. But during that compensatory pause, your heart is filling with more blood, right? Because there's a pause there. So the beat that comes after the premature one is always going to be a little harder than the one you had before. So it'll kind of be beat, 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 beat. And that's what people feel. Like when they say, oh, there's a butterfly in my chest. Like, boom, what was that? And that's because you have that harder beat afterwards. Now you can also have these premature beats that occur from the bottom of your heart. And so if you look out there at the very end, you see that weird looking beat out there. That's a premature ventricular contraction, came from the bottom of the heart. They always make the EKG look weird. And so, you know, you may get an EKG if you have to have surgery, and you'll have some PVCs on there. You'll go, oh my gosh, this looks crazy. This is not right. But again, it's pretty benign, but you'll see it. And so you can kind of see that the PVCs come in various flavors. So if you look at the top, there's 3 PVCs, but they all kind of look the same. If you look at the bottom, there's 3 PVCs, but the first and the third look the same, and the middle one looks different. So if it comes from a different place in your heart, it'll look differently, depending on where it started. Now, sometimes you can have them so often that you have this, which is called ventricular bigeminy, which means every other beat is a premature beat. You see a normal hill, then the abnormal, normal, abnormal, normal, abnormal. So you get into kind of a situation like that, you can see where people would be symptomatic from that, like every other beat's not quite normal. So what do we do with premature beats? Mostly I leave them alone, because generally they're not going to hurt you, and generally, you know, sometimes you don't even feel them. And so I tend to leave it alone, because why give you medicine for something that's not going to hurt you in the first place? Now, I have occasional patients that it really drives them crazy, and we'll put them on a little bit of medicine for that. But it's really not going to hurt you doesn't mean not going to feel it. You may feel it, and so it depends on how much you feel it. Do you want to do something about it? Most importantly, those lifestyle things that I talked about in the first slides is to avoid those activities that may make that happen. You know, look at your lifestyle and see if there's something you need to do. Hey, I'm not drinking enough water. Hey, I'm not sleeping well at night. Again, if it becomes limiting to your lifestyle, I'll put you on medicine. And there are occasional cases, like that bigeminy picture I showed you, where some people will go and have an ablation, where they burn that PVC out of there. But that's pretty rare, pretty rare. By far, the most common cause of palpitations. So when you feel it, I don't want you to worry, just, it's there. But that's usually what the cause is. Now, there's kind of 2 words I want you to know. One is called tachycardia. That means any fast rhythm. Just if your heart rate's over 100, it's called tachycardia. And bradycardia is any slow rhythm. So they're not very specific. Usually we consider bradycardia to be less than 60 beats per minute, so normal 60 to 100. But yeah, I gotta tell you, I got a lot of patients in my practice that live in the 50s, and they're doing just fine. So that even the 50s doesn't bother me particularly. So you can see it's an absolutely normal hill with the 3 little hills, but they just come a little slower apart from each other, okay? So generally not an issue, and actually bradycardia is not a very common cause for palpitations. So bradycardia means a slow heart rate, and frequently it's benign. So people will say, hey, how low is too low? What's the basement on my heart rate? Well, it's different for different people. You'll find people that have lived in the 50s, 50 heart rate for their whole life. If you take a marathon runner and just sit them in a chair for a few minutes, their resting heart rate may be 35. But you know, they have this super efficient heart. What are you going to do about that? You're not going to do anything about it. So if you look at the guidelines, there's no hard and fast number that says, oh, when you reach this, 40 or 38 or whatever, we need to do something. Because for different people, it's different things. I have people that live in the 50s. I have people that live in the 40s, and they feel fine. Now, I have other people, if they drop below 50, they feel like the world's coming out from under them, and so then you need to do something. What is the most common reason for bradycardia? Far and away, it's from one of the medicines that you take. There's a lot of medicines out there that slow your heart down. Specifically things like beta blockers, which is the metoprolols, the atenolols, the bisoprolols of the world. Also things like calcium channel blockers, diltiazem and verapamil. So the first thing you do when you notice a slow heart rate is you look at the medicine list and you try and get rid of what could potentially be causing the problem. The other thing you see is in well-trained athletes. More commonly with bradycardia, you don't present with jumping and skipping and hopping. You present with passing out, or oh my gosh, I have no energy. I can't walk from the couch to the kitchen. And so in those kind of cases, where you see here, you see the two little hills, and then you don't really see much in the middle right there. So that's a far more worrisome problem with bradycardia, and sometimes that means you need to have a pacemaker, okay? But before we put a pacemaker in people, you want to look at all the other things that could potentially be causing the slow heart rate. So just because you have a slow heart rate does not mean you automatically need a pacemaker. So let's move on now to the more common things we see, the tachycardias. That means your heart rate's fast. We got a lot of different varieties to talk about. Most of them in this category are quite benign, but there's one in particular that's a little more worried. And usually what people complain of is, hey, my heart's racing out of my chest. I feel it up here in my neck. Those kind of things. Actually, in the other place where we notice a lot is in people who use their O2 sat monitor on their finger, because it also gives you a heart rate, right? And so my Apple Watch told me I'm going 126. My little finger monitor said I was going 140. The other one we see commonly with bradycardia, people put that on their finger. My heart rate's 35. Well, if you have a lot of those premature beats, those little finger things won't count the premature beat, so it's only counting every other one. So a lot of times your heart rate's not actually that slow, it's just can't count it correctly. So this is what's called sinus tachycardia. Sinus means it came from the sinus node. It starts in the normal place. If you get up and go run around the block, you'll have sinus tachycardia. Your heart rate's supposed to go up. And so you can see the three little hills, but they all come really close together. That just means your heart rate's going faster. So this is most commonly not a heart problem. Like, oh, I'm having sinus tachycardia. Now look, I got some young girls I take care of, and their heart rate goes super fast when it shouldn't. But generally, this is really not a problem with your heart, but a reaction to something else going on inside you. Fear, anemia, fever, pain, stress, exercise, a bear's chasing you in the woods. All these things are going to cause your heart rate, to go up. And it's not going up because your heart is a problem. It's going up because, hey, something else is going on that's stressing me out, and I've got it, and my heart rate went up. So sinus tachycardia is very common, and usually we just look for the other causes of it. It's usually not that your heart is actually a problem. Now, there is a fast heart rate here that we do need to spend a little more time on, which is called SVT, which stands for supraventricular tachycardia, which means tachycardia, heart rate, fast. Supraventricular means it comes from the upper chambers of your heart, okay? Now, if you look here, it's a really fast heart rhythm, but you don't see three hills. You only see two. That's because there's a rhythm that is in your heart that has kind of taken over, and so because it's faster, it overrides your normal pacemaker, your sinus node. And so we'll see tracings like this. So SVT, supraventricular tachycardia, is kind of a garbage pail term. It's for any heart rate that comes from the top that makes your heart go fast. Most of these are quite benign. But if your heart rate, I've seen them go 190, 200, 230 beats per minute, and again, normal's 100 or less, you'll feel that. And some people feel, I feel a little bit, weird with that, or I might even feel like I could pass out. So you see very fast heart rates. A lot of these SVTs you can kind of break on your own. You can bear down like this, you can cough, and a lot of times they'll break. And so, depending on the type of SVT you have. So, most SVTs, we leave alone. Then, if it starts to become highly symptomatic, we can either talk about treating that with some medicine, or we can do an ablation. That's where they go in with the catheter and find where that rhythm's coming from and burn it out of there. Okay? Now, let's talk about another one, and this is the one that's in the more worrisome category. And in a room like this, I'm sure there's some people around that know what I'm talking about here. So this is atrial fibrillation and atrial flutter. Why do I list them together? About 20 years ago, they used to teach that these were two completely separate rhythms, but they're not. They're just peas in the same pod. And so it's a little bit more concerning of a rhythm. Can you go back one? No, it didn't go. Okay. It is very common as you get older. You get up over above 65, and you get up into your 80s, and it becomes very common. The biggest problem with fib and flutter is it significantly increases your risk for stroke, and we're going to talk about that in a minute here. The other worrisome thing about atrial fibrillation and flutter is some people feel it and some people don't. I'll have patients come to the office and I'll say, oh, you're in AFib today, and they'll go, you're kidding me, and they don't feel it. And then I have other patients within 3 seconds of going in, they know they're in atrial fibrillation. Why some people feel it and why some don't, nobody knows. But given the fact that it does increase your risk for stroke, it's very bothersome to us that people don't feel it. That would be a lot easier. So as our reminder, this is our normal rhythm, 3 little hills, right? So this is atrial flutter. You see how the hills have become, that looks almost like a sawtooth. And so that's what atrial flutter looks like. The bottom of your heart, the tall hill, is still beating like normal, but the upper chamber is beating really fast. Usually about 300 beats per minute. Now atrial fibrillation, the upper chamber is beating really fast, but more like 400 or 500 times a minute. Now, the thing you see here, do you see how irregular the rhythm is? It's not like music. It's like, there's no pattern to it. Because the upper chamber is up here like this, it's sending all these signals to the bottom of your heart, but only random ones make it through. So you always get an irregular heartbeat with atrial fibrillation. Now let's go back to our cartoon. If you remember there on the left, that's how our normal electrical system works. If you look on the right, you see all those big circles up in the upper chambers, and that's the atrial fibrillation. So the problem is in the upper chamber, and if you look at the upper chambers, normally the upper chambers should beat like this. And in atrial fibrillation, they're like that. Almost like a bag of worms. It just sits there and vibrates and really doesn't contract very much. So, what worries us about this? Who gets atrial fibrillation? Well, there's a lot of things. Your age. There's certainly a genetic predisposition if it's been in your family. Anybody that has pre-existing heart disease, high blood pressure, have previous bypass, have heart failure, have had a stent, any of those kind of things can increase your risk for having atrial fibrillation. Certainly excessive alcohol and smoking can do it. They see a lot of atrial fibrillation in New Orleans during Mardi Gras. That sounds like a joke, but that's the truth because of excessive alcohol intake. Stress and infection. So it's common, like when patients come in the hospital and they're septic or very, very sick, that the atrial fibrillation will kind of show its face. But I find this to be the disease that makes me look the stupidest, because most patients will ask me, well, what is it I did that made me go into atrial fibrillation? And my answer is, I don't know. And I don't. So we look for all these kind of things that, oh, if I just don't do this or I do that, I won't go in atrial fibrillation. But the majority of cases of atrial fibrillation, you don't really know for sure why you got it. So factors that increase it, So things that increase your risk for stroke. So I'm not going to get into the details. There's this little score we use called the CHADS-VAS score, and it gives you kind of a number. And based on that number, it looks at what your stroke risk is and whether you should be on some blood thinners. So age greater than 65 and certainly greater than 75 is a greater risk. Females are more common to have a stroke with AFib than the big ones: diabetes, high blood pressure, previous heart attack, or congestive heart failure. So you get a series of points for these, and if your point are 0 or 1, then you probably don't need any blood thinner. If you're 2 and higher, then you more likely do. So how do we treat atrial fibrillation? Now that's a loaded question right there, because it is a very complex way to manage it. So, because, I have patients that I take care of that have lived in atrial fibrillation for 20 years. They don't come out of it. They never come, I can't even get them out of it. And they learn to live in atrial fibrillation. And then I have other patients who, they go into AFib and for an hour and they're just feeling awful. So those patients you want to kind of put back in normal rhythm. So we have to decide, are we going to do what's called rate control or rhythm control? So if you have chronic AFib, meaning it's there, it's not going to go away, we've tried everything, we've done all these things to try and get rid of it, we can't get rid of it. So in those patients, what we'll do is just give them some medicine so that their heart rate doesn't go too fast. As you can see from our cartoon, it tends to want to really increase your heart rate. And so if we just keep your heart rate under control and give you some blood thinners, you can live a pretty normal life. Now, in other people who feel terrible when they have AFib, some people will go into heart failure when they have AFib. In those patients, we really, really want to keep them in normal rhythm. So that's a strategy called rhythm control. So sometimes we can do that with medication. There's a whole series of medications that can help to control AFib. And now, in this day and age, we have this thing called an ablation. This is where they kind of go in and burn it out, and they've gotten very good at that. But not everybody needs an ablation. Not everybody wants an ablation. So it's a little bit complex, and you need to talk with your cardiologist about what are our goals. Do we want to completely get rid of it? Do we just want to control it? Certainly in a patient that doesn't feel their atrial fibrillation ever, why would they want to go have an invasive procedure? So you've got to talk those things through. One of the first things we'll do when we first find atrial fibrillation, we'll start you on some medicine. Sometimes the medicine will put you back in rhythm, but sometimes we have to do what's called a cardioversion, and you've all seen this on television where we put the pads on you and we shock you, and so that's what a cardioversion is. Now we knock you out for it if you ever have to have it. The biggest issue is anticoagulation. So depending on what you look at, if you're an AFib or A-flutter, and you don't take any blood thinners, you have about a 6 to 10% chance of a stroke in any 1 year. If you take aspirin only, you've probably got about a 4% chance, but if you take blood thinners, which are things like Coumadin, warfarin, and now all these new ones, Xarelto, Eliquis, those kind of things, that lowers your risk down to about 0.8%. So the blood thinners are superior at keeping you from having a stroke. Now, that at a cost of an increased bleeding risk. So you have to be a little bit cautious and figure out, hey, what's worse, my risk of stroke or my risk of bleeding? And now we have this new thing called a Watchman, which is actually this little plug that we can put up into the left side of the heart where the clots tend to want to form. And so more and more people are getting a Watchman device and not taking. So those things were kind of designed for patients that couldn't or wouldn't take blood thinners. Patients that have had bleeding in the head or bleeding in their GI tract or, constant blood in their urine or something like that. And so that's why the Watchman was devised, because that was better than going with nothing. Although now we're getting to a case where some people are just wanting to have a Watchman and get off a blood thinner. Again, a complex discussion, but you need to try and do something if you have atrial fibrillation so that you don't end up with a stroke, because it's a real risk. So what should I do if I have palpitations? I wake up one morning and I'm feeling it. So you should, a lot of times it's easy to go, first go see your primary care doctor. They can get an EKG on you. or come see a cardiologist. So the first thing is get an EKG. Now the problem with an EKG is it doesn't always show what you got, right? An EKG is 10 seconds in time. So if you're in the abnormal rhythm when you get the EKG done, well then you've made the diagnosis. But more often than not, you're not in it. You know, it's like that squeak in your car, and then you take it to the mechanic, but you're not having it when you come to the cardiologist. So we start with an EKG. So the other thing we want to get is an echo. That's just an ultrasound of your heart. We want to make sure that, you know, your heart's pumping normally, that your valves are working. Is there something structurally about your heart that's making you more prone to having palpitations? Frequently, what we'll do is put a heart monitor on you because, you know, you don't have an EKG machine at home, and so we give you one to wear around for a while. And hopefully in that period of time where you're wearing that monitor, you'll have that rhythm problem, and it'll spit out an EKG for us, and then we'll know what to do. There are these things now called link monitors, which are, we just kind of inject it under the skin, and those are like one of these external monitors, except you keep it inside of you, just here under the skin, and that battery lasts for about 3 years. And so we do that frequently in patients who have stroke to see if there's an atrial fibrillation that caused their problem. You know, there are patients that come in with a stroke and, oh yeah, there's AFib on your EKG. More frequently, we don't know what caused the stroke. And so we have to make sure you don't have atrial fibrillation. And so sometimes we'll do that little internal monitor. Most of all, I don't want you to worry, which is easy to say and hard to do, because I'm feeling my heart right now and I don't know what that is. But if you look back at my presentation today, the majority of these rhythm problems, the majority are benign. You know, not going to hurt you. You may feel it, you may not like how it makes you feel, but not going to hurt you. Not going to increase your risk of a heart attack, not going to increase your risk of heart failure. You know, again, you want to have some peace of mind. You want to know what it is that's causing this problem, and we'll work it up. But the majority of the things that I talk about today are benign. And so that's a big talk that I have with a lot of patients is, okay, here's what you've got. You know, we'll get a monitor, and they may have had 5 episodes of SVT in 2 weeks. Okay, you know, yeah, you're going to feel it, but do you want to take medicine 24/7, 365 for something you had 5 times in 2 weeks? Other patients will come in and grab me by the shirt and say, this is driving me crazy, I got to do something about it. So, but again, it's not a life-threatening thing. Atrial fibrillation and flutter are in a little bit different category. The rhythm itself isn't going to tend to hurt you, it may make you feel poorly, but the biggest issue there is recognizing atrial fibrillation so we can, you know, talk about the blood thinner situation. I appreciate your attention, and I will take any questions you may have.
All right, who's got questions?
Okay, how do you know if you had arthritis or whatever, whether that's considered by being in the shoulder or whatever?
Yeah. So, you know, that's a good question, because not just even with palpitations, but chest pain or shortness of breath, or, you know, I feel my heart skipping. You know, there's a lot of symptoms that occur right up in here, you know, that can be heart, that can be musculoskeletal, orthopedic, your belly, your esophagus. And so I think the way I look at it is most of those things, arthritis isn't going to kill you, some reflux isn't going to kill you, but things about your heart can potentially be dangerous. And so, you know, going and at least getting at least a workup, get an EKG and maybe get an echo. You know, if your EKG and your echo look fine, occasionally if patients have a lot of risk factors, we may even get a stress test. Not always, but sometimes. And so those kind of things can tell us, is this your heart or is it not? And so a lot of times we do the workup, everything looks fine, and I'll say to you, hey, your heart's normal. And this is probably from, you know, arthritis or whatever. So, but it's not easy, and particularly in women. You know, women don't have, when they describe, hey, there's an elephant sitting on my chest, that was described in men. And so women have chest pain differently. It's not always this, I mean, there are plenty that have an elephant, but most of them are, my shoulders hurt, my neck hurts, my teeth hurt. I have pain right between my shoulder blades and the back. So I think particularly with women, we need to, as physicians, recognize that women present differently and don't just blow it off and say, that's nothing, you know? At least say, hey, that could potentially be from your heart. Let's look at that and see if there's a problem, okay?
Guys, that's some great advice, because how many of us do that? You know, you have this little symptom, and none of us wants it to be our heart, so we try to make it everything else but lest they really say, and that's such good information to hear some of the things that Dr. Schultz has taught us all today. So thankful for that. Now, I've got a question that I got before, so I'm going to throw that out there. So we go to our primary care doctor for our annual checkup, right? And you know, we're just wondering, is our heart working? Is it good? How can I be sure? You know, we've heard, you know, it can do all kind of stuff. Now, I'm going to tell y'all, when he was talking, I thought all those butterflies and all that heart beating fast or whatever back in our younger days, that just meant we were in love, right? and now we've gotten to the other side of life, and it means a lot of other stuff. So,
but it can still mean you're in love. I'm all right.
But anyway, I couldn't help but think about that. It's like, whoa, full circle here. But what should we ask for? Well, what does our insurance cover? How can we make sure that we've got a good heart screen? What test does that? And how do we get there?
So I'm going to start from the other side of that equation, in that I'm not a guy that wants to do a lot of cardiac tests on asymptomatic people. For instance, stress tests are designed to tell us, is the symptoms I'm having due to my heart? So the most important part of that question, or that sentence, is the symptoms I'm having. And so the problem with all tests is they're not 100% perfect. And so stress tests do have a tendency to give you a falsely abnormal reading. Now that becomes a slippery slope, right? Because, oh, your stress test is abnormal. Let's do a heart cath. Let's do an invasive procedure. Let's put a stent in you. Why are you going to put a stent in me? Because I want to make you feel better, but I didn't feel bad in the first place. So you don't want to just, you know, crazily check everything, you know, and just go, well, I hope I find. And you always hear the stories of people that get test after test after test, and finally one person out of 1,000 finds something, and that one person's happy that you found it, but I don't know if that's the most efficient use of your time or your resources. Now, when you're at your primary care doctor, I think the most important thing over any test is to be honest about your symptoms. If you're feeling something, tell them about it. You know, again, like you said, nobody wants it to be their heart, but ignorance is not bliss when it comes to your heart. You need to know if you have a problem. So be honest and straight up with your primary care provider and say, hey, I'm experiencing this stuff. What do you think? Certainly, I think at your primary doctor, they should be getting an EKG on you every once in a while. You don't need one every time you go in. An EKG, like I said, is very helpful if you're in the rhythm or the problem that you're having. If you're in the middle of having chest pain, EKG is fantastic to let us know if something's going on. But from a standpoint, it is 10 seconds in time. And so, but the most important thing about an EKG is not necessarily what it shows, but is the EKG changing. If there's a change in your EKG, that's really important. If it just kind of, and you, look, there's going to be probably out in this room, 50% of you have an abnormal EKG. It'll spit out abnormal at the top. Well, they're not all created equal. And so just because it's abnormal, as long as the abnormality stays the same, you're fine. So an EKG. And then I think from a heart standpoint, you need to be making sure that you're checking on the things that, you know, tend to cause heart disease. High blood pressure, cholesterol problems, diabetes, smoking, those things. So you need to be getting labs to check, make sure you're not diabetic. If you are, you need to make sure that your hemoglobin A1C is under good control. You need to keep your cholesterol down. They should check your blood pressure every time you go. And I think it's helpful if you check your blood pressure at home. Not 27 times a day, but on occasion, just to make sure that your medicines and things are working for you. And so I think that a lot of cardiac testing flows out of the history that you give your provider. You say, I'm having chest pain, I'm having palpitations, I'm short of breath when I lay down at night. And that will then dictate which test you go for. If you're having palpitations, we're more likely to put a monitor on you. If you're having exertional chest pain every time you take the garbage out, that's probably going to get you a stress test more than anything. If you can't lay flat at night because you're short of breath, then you're probably going to get an echo. So it does dictate what we want to do and what we want to check for based on what your symptoms are. And that's why I want you to be straight up with your primaries so that we can get you down the right path that you need to go. But don't just say, I'm fine. My male patients tend to want more that way than my female patients. But let us know. And it's once we kind of have a symptom to work with, then it's easier for us to kind of go down the right path.
All right, did that answer the question? Okay, good deal. Any other questions before we close out? Okay, Mr. Ron?
I hope this is a slightly off topic, but I suffer from what is called the white coat syndrome.
Yes.
And I don't understand how that operates.
Okay.
But anytime I'm in a doctor's office, it's way off the chart.
Sure.
And, I don't understand how that psychological or...
So that's very common. So the question's about white coat hypertension. Hey, every time I go to the doctor, and every time I'm at home, it's okay. So that does tend to be what I consider the physiologic response to psychological stress. Nobody wants to go to the doctor. No one wants to be there. There's another person in the room that has white coat hypertension, and he's talking to you right now. And I know all about it, and I'm not supposed to be nervous when I'm the patient, but I have the same thing. So, sometimes, whether it's conscious or subconscious, people will go to the doctor and go, okay, I got to show them that I'm taking care of my blood pressure. I want to get a good reading. And now I'm driving down 280 to get to there, and up it goes. And so it really is. I mean, it's kind of your body's response to stress. It's just the same as like the fight or flight response, bears chasing you through the woods, your heart rate goes up, your blood pressure goes up. It's the same mechanism. Your body releases a lot of adrenaline, which makes your heart beat faster and harder, and your blood pressure goes up. Interestingly, and so the issue with white coat hypertension is I try and be very careful about that, and that's why I want patients to take their blood pressure at home so I can compare. Because what I don't want you to do is show up at the doctor's office, oh, your blood pressure is 180 over 110, and then I throw you a bunch of medicine. The next thing we know, your blood pressure is going to be 90 over 50, and you are going to feel bad. So that's where a little bit of a home blood pressure check. And again, a couple, 3 times in a week is enough to check your blood pressure. But it is a physiologic response to some sort of psychological stress.
All right. Well, that's some good information. I want you guys to make note of that. And if it's not you, maybe it's somebody else. I'll give you a little personal testimony to that. Somebody called me a few months back and said, this is what's going on, A, B, C, D, but, and I'm not clinical. But you know what I did? I rolled back to what I had heard Dr. Schultz say a couple of times back. And I was like, you know what, I hear what you're saying, but I really think you need to get that checked out. So this information that we get can not only help us, but it can help our family, and it can help our community. So we need to, what we're learning, let's just take it out so that we all can be healthier as we move into the future. So, Dr. Schultz, thank you so much.
You're so welcome.
And yes, he's in our community, but I wouldn't ever not recognize the famous Jeff Harrell back there in the back. Stand up, Jeff. I'm not going to make you talk, just play. Jeff keeps us on track from a cardiac standpoint every day in Coosa Valley, and we're so thankful for him as well. So with that, you guys ready? Let's do some door prizes and get ready to move out. It's such a beautiful day. We should have been met outside today, right? All right. Well, while the girls are coming, 2 quick things. Friday is Wear Red Day in honor of Heart Month. So if I see you in town, I want you to have red on, okay? We may even snap your picture, but that's to bring more awareness to what we've heard today in so many heart diseases in men and women. So Wear Red Day, and then Rosa has left you a little survey. If you will fill that out, that's going to help us to be better, do more, bring the topics that you guys want to hear. So take a few minutes to do that, and then we're going to drum roll and do your process.